To open the next session, please welcome Dr. Arthur Jason Go, medical oncologist at UERRMC, San Juan Medical Center, Diosdado Capital Memorial Medical Center, Premier Medical Center and Central Luzon Integrated Oncology Center, Philippines.
Good afternoon, everyone. Our next topic is about the whole course management of chemotherapy-induced thrombocytopenia. Chemotherapy-induced thrombocytopenia is one of the most common treatment complications after undergoing chemo treatment. This causes a delay in treatment to the point that a reduced dose is needed to avoid complications such as bleeding. Our distinguished speaker, who will be discussing the whole course management of chemotherapy-induced thrombocytopenia and recombinant human thrombopoietin. Let me introduce our distinguished speaker who will be discussing the whole course management of chemotherapy-induced thrombocytopenia and recombinant human thrombopoietin. Our speaker is Professor Zhang Lingyun, who is a professor, chief physician, and a master tutor at the oncology department of the First Hospital of China Medical University. She is a youth member of the Society of Chemotherapy and the Society of Cancer Big Data and Real World Study of China Anti-Cancer Association, a vice chair of the Lung Cancer Group of Society of Cancer Precision Medicine and Big Data Management at Liaoning Provincial Society of Cell Biology, a standing committee member and secretary of the Sub-Society of Tumor Immunology at Liaoning Provincial Society of Immunology, and a director of the Society of Breast Cancer Precision Medicine and clinic research at Liaoning Provincial Society as well for cell biology. So ladies and gentlemen, let me welcome our Professor Zhang Lingyun.
Thank you very much, dear Dr. Asago, for your kind introduction. Dear doctors, dear friends, good afternoon. It's my pleasure to have today's opportunity online sharing the clinical experience from China. My topic today is the whole course management of chemotherapy-induced thrombocytopenia. My presentation would cover three parts. In the first part, let's take a look at what's the correlation between platelets and thrombopoietin. As we all know, platelet is formed from its precursors through a multi-step process, including stem cell, immature, and mature megakaryocyte. This process takes around 5 to 8 days. Usually, platelet lifespan is 9 to 12 days. As reported by many researchers, the platelet production in human body is regulated by a number of endogenous cytokines, among which thrombopoietin, as known as TPO, is the essential one. This animal study showed that the mice platelet count significantly decreased when either of their TPO genes or TPO receptor genes were knocked out. This data suggests that when TPO gene or TPO receptor was double knocked out, the megakaryocyte colony decreased to 5% of normal. The erythroid and myeloid colony also decreased. That means TPO serves primarily as a late-acting differentiation factor for megakaryocyte, but is also necessary for the growth and viability of cells of all ligages, including the pluripotential stem cell. In the second part, I would show you the epidemiology of CIT. The cause of thrombocytopenia are mixed. It can be triggered by certain disease, including immunity and non-immunity, such as ITP, CIT, virus infection, etc. The definition of CIT means lower platelet count in peripheral blood than normal, resulted from the inhibition mechanism of anti-neoplastic chemotherapy drugs on bone marrow, especially on megakaryocyte. As just mentioned, the platelet production is a multi-step process. From this flowchart, we can see that different chemo drugs affect the megakaryocyte and the platelet production at different steps. Some reduce platelet production, while some can actually promote the destruction. Based on the real-world data, the overall incidence of CIT was 9.7%. The incidence of CIT in regimens containing gemcitabine and platinum was higher. As oncologists, we all know that the hazards of CIT not only threatening patients' life, but also causing dose reduction, dose relay, and increasing the treatment cost. In order to better treat CIT, whole course management strategy is widely being used by Chinese oncologists. Here is our experience. Regarding CIT treatment, the overall goal is to reduce the risk of bleeding, ensure that radiotherapy and chemotherapy are carried out in time and in sufficient dose, and guarantee the benefits of treatment. The concept of whole course management of CIT means a systematic long-term standard plan is formulated for chronic disease from diagnostic treatment, side effect treatment, follow-up, and end of life. And the treatment and follow-up are conducted under the guidance of doctors for life. The scenario is to establish a standard treatment regimen covering the whole course management of CIT at each stage, from the very beginning of clinical manifestation, diagnosis, chemotreatment till the patient is discharged from the hospital. The whole course management of CIT focuses on three main links. During the process of diagnosis and assessment, we need to know some diagnostic essentials. For instance, the peripheral blood platelet count less than 100,000, application of thrombocytopenic chemotherapy drugs before the onset of the disease and recover gradually after the drug withdrawal. Thrombocytopenia reappear after reusing the same chemotherapy drug, excluding other causes of thrombocytopenia such as chemotherapeutic drugs and pseudo-thrombocytopenia. For the treatment in 2018, the Chinese Medical Society published an expert consensus on the standard treatment of CIT. It is now the practice guideline for Chinese oncologists. From this decision tree, we can find that if the bleeding happened, patients should receive the platelet infusion plus or not TPO. If no bleeding, individualized therapeutic regimen should be made according to the platelet count. Currently, there are several drugs approved for alleviation of thrombocytopenia. However, only interleukin-11 and the TPO are indicated for CIT. Low platelet transfusion is the most direct way to increase platelet count. Not all CIT patients are accepted to it. As 2014 US AABB platelet transfusion guidelines reported, platelet therapy should be given for adult inpatients with platelet count less than or equal to 10,000 to reduce the risk of bleeding. Moreover, transfusion can bring the risk of AIDS, hepatitis, ineffective transfusion, and immune reactions. The thrombopoietic agents, interleukin-11 was approved by FDA to treat CIT in 1997. However, it has its own obvious shortages. First, common adverse reactions include water sodium retention and arrhythmia, which may lead to severe cardiac toxicity. Second, the interleukin-11 is only effective for megakaryocyte polypoid, so it has low specificity of action mechanism and a narrow action range, so its efficacy is quite limited. Currently, a no treatment based on TPO receptor is emerging, including TPO, ultrabumpag, and romiplastin. TPO was first approved by China FDA in 2005 for the treatment of CIT. In 2010, another new indication, ITP, was approved as well, but both ultrabumpag and romiplastin are indicated for ITP. This is the summary of comparison. TPO is full-length protein, regulating the whole thrombopoietic process from stem cell megakaryocyte to platelet. While for ultrabumpag and romiplastin, their effect is very limited during this process. As we can see, the TPO has the same structure, same molecular weight as the endogenous TPO produced by human body. So Rh-TPO plays the same biological function as endogenous TPO in terms of efficacy and safety. The therapeutic treatment of CIT should be individualized based on different platelet count, the efficacy and the safety of drugs. From this decision tree, we can find that TPO is frequently recommended in the individualized treatment of CIT based on its good efficacy and safety. Such is the dosage and administration of TPO. It should be administered by subcutaneous injection in 6 to 24 hours after the end of the chemotherapy. The treatment course usually is less than 14 days. When the platelet count recovers to 100,000 or more, or the absolute increment of platelet count is more than 50,000, the TPO should be withdrawn. Also, we should use TPO as early as possible. The study found that the platelet recovery time and the TPO use time are the most shortest in grade 2 CIT patients. Also, the platelet infusion rate is the most lowest. This perspective parallel control study showed that the patients who receiving TPO had significantly higher minimum platelet count and shorter duration of grade 3 CIT than those receiving interleukin 11. The time to recovery to normal platelet count is also shorter with TPO than in interleukin 11. In treating severe CIT, the platelet count less than 50,000. The TPO is also better than interleukin 11 in terms of duration of grade 3 to 4 CIT and the platelet transfusion rate. A meta-analysis including 10 studies and 532 patients in China shows that the adverse reactions of interleukin 11 were significantly higher than TPO, such as edema, palpitation, and arrhythmia. As the American Oncology Nursing Society guidelines highlighted, patients with previous fluid retention, congestive heart failure, atrial arrhythmia, or history of coronary artery disease, especially elderly patients, are careful to use interleukin 11. For patients with high risk of hemorrhage, to prevent severe thrombocytopenic recurrence, secondary prophylaxis is recommended. The secondary prophylaxis can be adopted if one of the following conditions is met, such as the minimum platelet count in the last chemotherapy cycle is less than 50,000, or the minimum platelet count in the last chemotherapy cycle is more than 50,000 but less than 75,000. Meanwhile, at least one of the following high-risk factors for bleeding should be met, such as a history of bleeding, receiving chemotherapy containing drugs such as platinum, gemcitabine, and anthracycline, or combination of targeted drugs and chemotherapy drugs that both easily lead to thrombocytopenia. Thrombocytopenia caused by bone marrow infiltration of tumor cells. ECOG scores more than 2. History of radiotherapy or ongoing radiotherapy, especially on long bones and flat bones. This is the application method of secondary prophylaxis. TIPO should be adopted within 1 to 2 days after chemotherapy, using TIPO every day or every other day for 7 to 10 days. For chemotherapy cycle including GC or GP regimen, we can use TIPO in day 2, 4, 6, 9. The TIPO needs to be given early, before, and after chemotherapy. As just mentioned, platelet level should be monitored regularly during the treatment, and drug withdrawal indications should be standardized. For surgery patients, if the platelet count is between 75,000 and 100,000, and there is no bleeding, the TIPO and or interleukin 11 should be considered to meet the surgical requirement. We also need to consider the risk of venous thromboembolism in tumor patients. Also, nursing care of CIT patients in hospital is very important, including knowledge education, disease condition observation, diet nursing, psychological care, and medication guidance. The whole course management of CIT also focuses on out-of-hospital management. A real-world data shows that 2/3 of CIT occur outside of the hospital, so we need multi-party collaboration. We need the collaboration between physicians, nurses, and patients and caregivers. In summary, the whole course management of CIT currently is widely employed by Chinese oncologists. And TIPO is a novel TIPO receptor-based drug recommended by Chinese expert consensus on the standard treatment of CIT. Owing to its reliable efficacy and safety, the TIPO plays an important role in the whole course management of CIT. So that's all for my presentation. Thank you for listening.
It is a privilege to introduce our distinguished reactor, Dr. Antonio Villalon. Dr. Antonio Villalon is the past president of the Philippine College of Physicians, the past president of the Philippine Society of Medical Oncology, also the past president of the Philippine Society of Oncology. He established the first local fellowship program in medical oncology at the UP Philippine General Hospital, revived and reorganized the Philippine Society of Medical Oncology. To complement the multidisciplinary approach to cancer treatment, he founded the PONA, the Philippine Oncology Nurses Association. He also co-founded the Asia-Oceania Clinic Oncology Association and the Asian Clinical Oncology Association to promote cooperation among oncologists in the Southeast Asia. Recently, he was received the Philippine College Physician Exemplar Award as a distinguished internist in 2020. Currently, he is the chairman of the Manila Doctor Hospital Cancer Institute.
Thank you, Professor Zhang, and good afternoon. The incidence of chemotherapy-induced thrombocytopenia in the Philippines is actually higher than in the literature. This is followed by thrombocytopenia, which we see secondary to bone marrow infiltration by tumor cells. The most common use of thrombopoietin is in the prophylaxis for platelets less than 50,000 or 50 times 10 to the 9th, and as treatment for bleeding in the form of petechia, ecchymosis, or tarry stools. Our problem is our baseline blood count assessment before we start chemotherapy, especially in those with low platelet counts. For acute bleeding, blood transfusion is indicated because it increases the hemoglobin immediately, but the effect is of short duration. There's also the risk of hepatitis or allergic reaction. Thrombopoietin induced its effect gradually, but is of longer duration. It can be given in different schedules, but due to its cost, it is given 1 to 3 times or when needed only, rather than every day for 14 days. No doubt, chemotherapy-induced thrombocytopenia is a problem, and thrombopoietin will be important in the overall management of chemotherapy-induced thrombocytopenia. Thank you very much.